right. Well, we're both, I'm sure, I'm speaking for Rachel as well at the beginning, really delighted to come talk to you about our work. And the way this is going to do, since we're tag teaming, is that I'll start out first and provide some framing for what you're going to hear. Then Rachel's going to dive a little bit deeper into what we've actually been up to. And then we'll have some takeaways and pros. There's different points for interaction, but we definitely wanted to save lots of time for questions at the end. So we hope to hear from you quite a bit about that. So the writer Ursula Le Guin once pointed out there have been great societies that didn't use the wheel, but there have been no societies that did not tell stories. Stories are an integral part of our lives. And in some ways, there's been a lot of research to suggest this helps us in our search for meaning, about what this conference has been about, and that we're hardwired to look for those patterns. So this was shown in a landmark experiment that was done at Smith in the 1940s. And what the researchers did is put up something that was kind of like the following animation, but of course, this is adapted to PowerPoint. So I'm going to ask you just to shout out, what did you see? What did you notice? Okay. Mm-hmm. Okay, so this is a pretty analytical audience, and we're hearing exactly, very descriptively what people saw. But when they did this experiment with over 30 people, what they found was that people actually told stories. They went ahead and said, well, that circle was a little worried. They were running away from the big triangle. That little triangle was a little scared, and we had to protect that young thing. And every single person of those above 30s did that except for one. And so that was sort of the beginning of this idea that, I think we try to find patterns. And really what we're trying to do, other research would suggest, is we take these random events that occur in our lives and we try to create them into a pattern to think about order and how they fit together. I think many of us in the healthcare setting have experienced this with our patients. The first time that somebody is introduced to the idea of a chronic disease, and their identity of who they are changes because now they have to take a medicine every day. And how they integrate that into themselves and their whole being really can affect how they interact with us. Maybe they don't take that pill and they're termed, non-adherent. Or they search for other things that are more under their own control instead of having to show up to a prescription and get their prescription filled. So interesting research has been done into why do people tell stories? And you can imagine it's a lot of different things. Things like creating connection, maybe passing on lessons learned or things that were gained in terms of meaning when times have been difficult, or just, to be an entertainer. Some other research has been shown at Stanford to say that compared to facts and figures, people remember stories 30 times more. So stories are definitely an integral part of how we communicate with each other. So one of the coolest things, in my opinion, is this idea of neural implanting, which fMRIs are making possible. So what actually is happening when you're telling a story? And what they do is they wire both the storyteller and the listener up, and they image their brains in real time to see what's going on. And interestingly, as the storyteller is talking, and let's say they're describing a sad story, their feeling center is lighting up, the listener is having the exact same area light up in their brain. So just for that moment, those two brains are completely in sync with those stories. And then afterwards, what happens is an integration of that experience into what the person's own experience has been. So with that foreshadowing, we're going to move into our research, which is talking about how we're working to create a database in the United States of patients' experience, really moving from the me to the we.
So lovely to be with all of you. I feel extraordinarily lucky that my job really is to ask people to tell me their story and then to listen really hard. And that is a very wonderful job to have, particularly since I'm not meant to fix them in any way. So the story is itself the medium of the interaction. And this database of individual patient experience initiative that Nancy and I have been working together to nurture and grow and learn from and contribute to in the United States is a wonderful way to hear those stories and to ask for them. It's a methodology that systematically connects stories to understand how health and healthcare is being experienced in the broadest way that we can define that, so with a maximum variation, different peoples, different stories all around the country. And then using results to support other people who are going through those kinds of experiences by creating a public-facing website. More specifically, we go out into people's homes with a video recorder, and we're going to show you a few clips to listen to in a few minutes, asking people for their stories. And here is a view of the website that's out of Oxford University that pioneered this methodology. The website is used most of all by other patients and caregivers to get a well-rounded view of experiences with everything from cancer to primary care to having a child with ADHD. Oxford's done more than 80 of these studies, and you see here a little view of their website. Here's an example of a module, these web-based public-facing tools are called modules, and this one's on what is good healthcare, something near and dear to us at DFMCH, and there's interviews from people all around the United Kingdom on this topic. What does good healthcare mean to you, whether you are homeless, whether you are a wealthy person, you're black, you're white, you have a lot of healthcare, a little healthcare. Again, that maximum variation. This work is being done in 9 other countries around the world, and we are very proud to be the 10th country to join this collaborative to systematically collect these in-depth stories, to use them for research, and also to use them as a very accessible tool that patients as well as clinicians and medical educators and researchers and policymakers can get hold of to understand not just patient voice, which is sometimes talked about in the singular, but patient voices in the plural, again with this rigorous maximum variation methodology as well as qualitative analysis. One of the reasons that we've been so attracted to this, Nancy and I have been having a lot of great conversations about this lately, is the power of engaging more quiet voices. And we've talked about this here. Jennifer was talking about the quote-unquote difficult patient. How do we find our own inner voice? We've spent a lot of time on this already this morning. It's easiest in our society to hear that sort of extroverted voice, right? And we've heard from Susan Cain in her very famous book, Quiet, that some of you may have encountered, and other literature coming out about introversion and extroversion, about this kind of bias towards the extrovert ideal. The quiet voice, the person who's not going to storm City Hall, is not going to go to the media, is not going to make sure that what they have to say is heard, that voice needs to be elicited. The gift of that voice needs to be asked for. And this is a wonderful methodology for sort of leveling that playing field, because we ask people, will you be willing to tell your story about health and illness to help other people, and to kind of begin addressing this bias towards institutions that really favor the person who's going to get their voice out there probably anyway. And then again, through this tool, through the analysis, through the website, and the dissemination of what we've heard from patient voices in the plural, to amplify those voices and really kind of democratize what we hear about from patients in public, so we have a more complete view. We know there's a great hunger for this kind of work in the United States. The UK Health Talk Online website that we showed a minute ago is visited by we are a larger percentage of the user population in the US than they are in the UK, and it's very well advertised and publicized. They've won billions of awards. It's a very well-established institution in the UK, but still, we are more than 40% of their users, even though they're not American experiences. They're experiences in the UK. And this is an old number. They are now projecting 2 million visits for 2015 to that website from here. We are not doing this alone. Nancy and I are very much with each other. It's been such a fun collaboration, and I think having both of us stand here really kind of shows you what it's like, because we're shoulder to shoulder doing this so much of the time. We have a larger team here in Madison, and we also have partners at Oregon Health and Sciences University, at Yale University, and at Johns Hopkins who are helping us to launch this. We're really proud to have the first study and module going here in the U.S. It's a study of young adults with depression, an area where Nancy has so much expertise. And young adulthood, for lots of reasons, but including that it's a time of such transition with graduations and weddings and moving into the workforce and who am I now and moving away from my home of origin. We know that depression's really prevalent in that population. We've been interviewing in all of these places that have stars on them, again, in people's homes, and we're heading to the south, we hope, before we finish. And here's a view of the flyer that we've been using, asking people to tell us their stories to help other people feel less alone. And now I'm going to have a vulnerable moment with the technology because we loaded a sound file on here, but I don't see it, so I'm going to have to go get it for a second while I'm telling you why we want to play this for you. So we have heard so much from people that we're interviewing about the power of storytelling to them, and I'm going to play you. So here, I've got this right here. I'm going to play you clips from 3 people that we interviewed, and then we're going to ask you to listen. This is bringing some patient voices into the room, depressed young adults who we've interviewed, to listen for why story mattered to them. And then we're going to ask you to tell us a little bit of what we heard, and then we're going to go back to Nancy.
So, to be truthful, I probably went back to it 5 times before I reached out to you. I kept going back and forth feeling like this would be really great and I want to contribute, but I don't know if I really feel like talking about it. And it was really like 5 or 6 times that I went back. But I really just felt like I've been through what we discussed is like the tip of the iceberg. I feel like I've been through so much for reasons that I might never really understand, and that's okay, but I feel like my experience is valuable in teaching other people, and I think something that helped me, and I should have mentioned this earlier, was that listening to other people's stories was always helpful for me, especially listening to people's stories where they were in a more positive place at that point in their life, so it kind of gave me the hope that, like they've been through this and now they're in a good place. And
probably mostly because I hope that it will at least help. If it helps maybe one person, then
Sorry guys, I don't know how to make this louder.
it's something I've always wanted to do. It helps them realize that they aren't alone.
He's talking about how if this can help one other person who has anorexia and slightly loopy
You're not
parents.
insane for thinking that.
That's why he wants to be
nobody
doing
will
this
believe you.
interview.
I've dealt with that as well. Or if your parents are a tad loopy like mine are, you're not alone. Just as long as it helps, one person to realize that it'll be okay, then I've fulfilled somehow.
I really think that there's someone else out there that probably has the same issue that I'm going through. And if I could help them if this is anything worth to them, if this can stop them from doing something self-destructive, then that makes me feel better about myself. That makes me less depressed because I'm helping someone that's in the same situation as me. I was maybe 1 or 2 wrong turns from just taking my life. If this can be something that can help another person, that can give them the right decision that I made, I'd be happy to do it.
Yeah.
Every time. I don't regret it. So, yeah.
Okay. So, sorry for the really quiet voice there. We didn't realize how very quiet that voice would be. But any responses to sort of what you heard from people about what stories mean to them? Yeah.
Why do they all want to help somebody? I thought that was interesting. Why is that important?
Yeah, I think when you're depressed, the idea that something you could do would be of use to other people has been really, really powerful. And people who are in a lot of pain, even at the moment of the interview, have been very willing to do it, which has been amazing and gratifying for us.
One of the things that seems to mark people who are doing well in early 28-day addiction recovery is when they start to really look after people who are new in the program and start to take in narratives, positive or negative, as relevant to their own narrative, their own path.
Right, and we heard that first woman saying, well, it was amazing, I wanted to do this because I realized how powerful other people's stories have been to me.
So here you can see we were showing you just a few clips, but you can see some more of the faces of the people that we have been interviewing. And as you can see, it's hard, as one person refers to, it's the tip of that iceberg when you just see a visual image. But we've been very gratified that we've been able to get lots of different kinds of people coming from different walks of life and different experiences. Everyone from folks who are transient and aren't really sure what's going to happen. People end up in the hospital after our interview, and that's been just amazing to hear across these stories. What do people have in common and where are the differences? So now I'm going to close with just some information, some pearls about how you can bring this home into your practice. And I'm going to use some quotes, and the reason I'm reading them is it's just a little faster than showing those videos. So first I'm going to read a quote from a participant about how isolating it can be to receive a diagnosis. I feel like we all feel just like, why us? What's so different about me? Why can't I just be like everyone else? Life is so hard on its own already. Why do I need any more? It's just not fair. So one thing we did was we asked all our participants about what advice do they have for health professionals. So every interview we do, we say, what would you say if a health professional was sitting right next to you? And I'm just going to capture 3 major points of what we've heard. We've heard over and over the importance of being present and listening. So this participant illustrates this by saying, I tell them to just listen. They, meaning a patient, don't need to be pushed away with just quotes and a prescription. They need to cry. They need to share their stories without judgment. I just tell them to not be so quick to write a prescription and to not just be dismissive with their notes. Don't just think about the money. Don't just think about just getting that person out of there. Another one talks about what it means to be supportive. Don't expect to understand what that person is going through. In all honesty, I don't want someone to understand because that sucks to, what this feels like. I just want them to be supportive, which is different. Being supportive is not even the willingness to understand. It's the willingness to never understand and to still be there. And the last quote I'll read reminds us that it can take a while for a person to get better. But remember, patients are coming in and seeking help for a reason. I would tell that person to hang in there. I would encourage that person that their work is meaningful and that they are making a difference and that person is sitting there with them and they don't have to be. So all of us are privileged to hear and be a part of people's stories. Our research participants remind us that our work can be a path that feels meaningful to the me and then also supportive to the we. So I invite you to stay tuned. This will be the website in the U.S., healthexperiencesUSA.org. We hope that you'll share it with your patients, with the young adults with depression, if you think this can be of value. It should be going live, probably late spring, so we're at the cusp of getting this going. And I want to just end with acknowledging all of our funders who are all within UW Health, and particularly our department, just for having the foresight to realizing that this could be something that would be powerful for people to have. So with that, we'll answer any questions.
I feel like a lot of my patients that have mental health concerns feel really relieved and better, at least to be able to share their experience with me. But I like what you've been doing and that you can amplify their voice. How do you feel like we could do that for patients that are willing to participate? I mean, like without necessarily having to be in contact with you.
Yeah. So I think one of the things that I definitely learned in the process of doing this study is how much, for our patients who are internet savvy, that there are places to share your story. And so one of the things that we'll be doing is we'll have resources and connections as part of the website, but I think a lot of people are cluing into this idea right now, and NAMI, several support groups are providing that. So we will have a list of resources, and I'll be happy to send that out sort of, all DFM wide once we collate that, so that it's not just about going to the website. It can be sharing your voice in other ways.
I immediately thought Facebook, because a lot of people are sharing their stories in Facebook, whether you want to hear them or not, in a very personal way many times. And I was listening to the public radio the other day of the power of Facebook as a huge support group for people that want to tell their story to each other.
Yeah, I mean, there's so much happening in the social media landscape, so many ways people can connect, and they can blog, and they can tell their stories, and all of that is very wonderful. This is a little bit different because it is a social scientific approach. You have to have a senior qualitative researcher and a clinician team up to do this work. That's the way it's done all around the world where it's occurring. And so the value of this kind of tool that's not instead of, but is in addition to that, is that there's been that effort to capture the variation in experience. There's been a rigorous analysis to determine what is thematic, what we're hearing over and over. And as Nancy was just mentioning, on every page of the website, which has these embedded video clips of people talking in their own voice instead of us summarizing for them. So it's got that power of immediacy and voice. There's also the clinician's viewpoint, what we know from the scientific evidence base, and a connection to resources. So it's got a reliability that not everything, we know this pretty well, on the internet has, and it has a really gold standard reputation, which is why, again, we had that map of all the countries. You have to go through a process to become sort of anointed as a country team to keep that standard live. And there's a wonderful collaborative both in the U.S. and internationally to make sure that we're sticking to that gold standard.
So, a lot of social media, there's a not so great vulnerability, and there's a lack of safety there. So this sounds like it's much more supportive in that sense.
Yeah, so I think one of the things we didn't mention was that people are really being brave with telling their stories. And so it was important for us when we did this work is that they own their story. So the consent process is that, this is their transcript and they get it back. They can watch the video. They can say, oh, no, I didn't really want, what I said, that bad thing about that person, to be public. So it's really all the rights are within the patient, which also ensures safety. We also are doing this work with an advisory board. Dave Rakel's one of the members. So we have professional members from different walks of life. And then we have patients who are interviewed themselves as part of that advisory board. They actually came in from all around last night to help us to understand, what felt safe and what didn't feel vulnerable. So it's very much being co-designed together as we put the website up.
Excellent. Thanks, guys.
Thank you.
Appreciate it.